All right, we'll go ahead and get started. On behalf of Florida Department of Health in Volusia County, welcome to the 2021 Path for Hope Virtual Summit. My name is Marisol Baena, and I will be the facilitator for this session. You have joined the session titled COVID, Overdose, and Death Certification. All participants will be muted during the session. There will be a question and answer time at the end of the session for you to post your questions. You may raise your hand using the reactions button at the bottom of your screen. We will then call on you and allow you to unmute yourself. You may also submit questions during the presentation in the chat box, and we will post the questions to the presenter at the end of the session if time allows. Thank you to the Path for Hope Summit Planning Committee partners, which are Advent Health, Community Coalition Alliance, One Voice for Volusia, SMA Healthcare, and Volusia Recovery Alliance. It is my pleasure now to introduce your presenter for this session, Dr. James Fulcher, the Volusia County Chief Medical Examiner. Prior to serving as the Chief Medical Examiner for Volusia County, Dr. Fulcher served 10 years as the Chief Deputy Medical Examiner for Greenville County in South Carolina. He attended medical school at the Medical College of Virginia, completed anatomic and clinical pathology residency at the Medical College of Virginia, VCU School of Medicine, and a one-year fellowship at the Chief Medical Examiner's Office in Richmond, Virginia. Dr. Fulcher's professional interests outside of forensic pathology include education of all sorts. Welcome and thank you, Dr. Fulcher.
Thank you, I appreciate it. That was a lovely introduction. I'm happy to be speaking to everyone. This is going to, I think, be an informative and interesting presentation. I have to give credit to people that helped me produce this presentation. The statistical numbers you see here are based on the annual report, which my office provides to the county every year. You'll see some shocking statistics there. And then the other part is a study I'm involved in South Carolina, where I was for 10 years, on death certification in a hospital setting and the errors clinicians and providers make when they're certifying fatalities and deaths, and how that affects the interpretation and coding at a global or national level. So all related to overdose and also COVID. See if I, oh, there it is. So our objectives very briefly are basically to describe what I do, evaluate the effects of COVID-19 as they relate to overdoses in particular, review our relationship between clinicians, providers, and how we certify and report fatalities, with a special interest in how overdoses are reported to us and how we investigate those cases. And then finally, we're going to review some parts of the death certificate, how to appropriately complete it, and then review what type of errors occur commonly when clinicians and providers are filling out death certificates. So a few things right off to start. And you know, physicians, providers, you guys have very little training in what we do, formal training in your school. Obviously, we are the redheaded stepchild of the redheaded stepchild of medicine. No one really talks about what we do. In my pathology residency, we quite literally, this is a 4-year residency, anatomic and clinical pathology, we had 1 hour where a medical examiner spoke to us, and then we had a required 1-month rotation just to get autopsy numbers, basically. So it's not your fault that you don't understand what we do, and it's not really your fault that you don't understand what our legal jurisdiction is. But hopefully we're gonna work through that today. So we don't take jurisdiction over the vast majority of people that die in our county. And more importantly, even if we take jurisdiction over a case, we do not necessarily autopsy that case. As you can see, in 2020, 8.7% of the people that died in my county were autopsied by my office. That's actually a pretty high number. That can drop as low as 5% in certain jurisdictions. In a perfect world, more people would get autopsy. It's exactly like your work. There's simply not enough funding to autopsy everyone that you really love to autopsy. The state of Florida has no legal mandate that we determine, and this is important, the exact natural cause of death in a decedent. So if you're a 57-year-old obese smoker with hypertension and other things, and the family just wants to know why you died, that does not meet medical examiner jurisdiction for an autopsy, because we've ruled out unnatural or unexplained death. Our function here is to make sure that we're not missing homicides, suicides, accidents, or very much unexplained deaths in younger people. With that said, COVID was under our jurisdiction until August of last year. Essentially, as a threat to public health and infectious disease, it fell under that purview. The efforts that it took for our offices to do chart evaluations, limited autopsies, limited external exams, mostly just chart evaluations on all the people that were dying of COVID, basically broke the system in several jurisdictions. Volusia County was lucky in the beginning that we did not have a huge spike, so my office held up quite nicely. Offices in South Florida, where there was a much more significant early spike in fatalities, those offices essentially went to the MEC and begged them to remove COVID from our jurisdiction. It really made sense. You guys were doing just as good a job at certifying these deaths as we were. We were adding little value to the total equation at immense burden to ourselves. So that was a good move. So my data on COVID, all medical examiners' data on COVID is screwed up in this state because we had jurisdiction, then we didn't have it. And in the span of literally a meeting, like an hour, jurisdiction went away. So how we treated these cases was very, very different before and after that August meeting. So that's maybe confusing if you get into any of that data with COVID and medical examiners. So let's get into what 2020 looked like for my office. Of the 8,290 people that died, 2,332 were reported to us. What were the other almost 6,000? They were obvious natural deaths in people where death was expected and a physician or provider was willing to certify the death. That's what those are. Those are never our jurisdiction, and they actually are not jurisdiction in any state in this country. You would not take jurisdiction over those obvious natural deaths. It's not our responsibility. Of those 2,332, we accepted 1456. The ones that were declined were things where either by hospital policy or hospice policy, these people just call us just to give us a heads up that this person died. And we looked at the case and decided it did not meet our jurisdictional requirements. So the 1,456, those had some sort of investigation. Some were autopsies, some were chart reviews, some were external exams. And what I've described there is exactly what it sounds like. If it's an external exam, it's we accept the case, we sign the death certificate, we pull the records, and we certify the death based on that record review. A great example of that is the older person that falls and breaks their hip. It's well documented radiographically. The attending physician believes that's the cause of death. We're called because it's technically an accident because they fell. Investigation at the scene or per reports of the nursing home or wherever, there's no suspicion of foul play. No one pushed this person down a flight of steps. This was a reasonable witnessed fall at home, expected because of this elderly person's comorbidities. That is a case we would do as a medical records review. The next type of case we'll do is an external examination. And that is essentially an evaluation of the outside of the body, plus or minus toxicology and any ancillary studies. We do this in cases where an internal examination would not yield additional critical information. A great example of that would be a very catastrophic motorcycle or vehicular accident where there's incredible damage to the head, brain's actually loose on the scene, something like that. We can look at that body and very definitively tell you why they died. It's no mystery to anyone there. You don't have to do an autopsy in those cases. And in most jurisdictions in the country, those are not autopsies. We will autopsy those motor vehicle accidents if there are criminal charges pending. So that's the one caveat there. And the balance of evaluations we do are autopsies. An autopsy includes removal of the viscera of the body, examination of that viscera, and potential microscopic examination of those tissues. We can modify autopsy to include either a head, chest, abdomen only, or all of the above. One of the things we changed during COVID, which we've since kind of gone back to with the Delta variant, is we are being more judicious about the number of heads we open and brains we examine because we're worried about bone dust spread of COVID. Low potential risk, but if we have a good cause of death without looking at the brain, we try not to do it if possible. That's been a big change for a lot of medical examiners' offices. So those are the types of things we might do. Of those cases that we took jurisdiction over, 447 were in fact accidents. 334 were accidental drug overdoses. The rest were falls or motor vehicle accidents, stuff like that. Drownings, obviously being a coastal community, we do a lot of drownings and such. But here's where it gets interesting for everyone in this field. 344 were due to accidental overdoses. Of those 344, 294 involve fentanyl. And when we say involve fentanyl, meaning it is a direct contributor to cause of death. They probably, I can't say on all the cases, but the vast majority of these people might not have died but for the concentration of fentanyl in their body. That actually ends up being 3.5% of the deaths in the county have some relationship to fentanyl. 20% of the cases we accept have some relationship to fentanyl. And this is shocking. You know, way more people die of fentanyl overdoses now than motor vehicle accidents. Significant increase, almost double. In fact, less suicides than fentanyl overdose. I should say, it was asked when I presented this information to County Council, nearly all of these overdoses are accidental. The vast majority are accidental. We have very few suicidal overdoses. The majority of our suicides in this county, much like the rest of the country, involve a firearm. Usually a handgun, usually a single gunshot wound to the head, followed by gunshot wounds to the chest, followed by hangings, followed by other things, cutting and incised wounds. But the vast majority of suicides are handgun related. So this is what our year looked like in 2020. You'll note we got busier. We accepted a lot more cases, but we also declined these cases. And these declines don't mean we didn't do a workup. These are cases where we evaluated the case thoroughly and then decided it did not meet our jurisdiction. So both the blue and the orange here represent hard work by the office. My ops manager is a UF person, so that's why we have this coloration. So this is what we did with the cases, and you can see everything really went up. Our death certificate only or medical record review cases went up. our external exams went up, and our autopsies went up significantly. And this is by manner of death. And what I've drawn here, oh shoot, I've drawn, I'm going to move this little bar out of my way. This number, the natural, this represents the uptick, the increase in cases from 2019 to 20. This entire triangle is COVID related. If you mirror this curve up here, this entire angle is overdoses. So you can see between COVID and overdose, that's what drove the increase for this year. Motor vehicle accidents actually kind of went down a little bit. And here's that just graphically shown how dramatic accidental drug overdoses increased in our county. I will tell you, not every county in Florida had an increase. We had a significantly higher increase. I think that's multifactorial. I think that as a recreational destination that isn't as opulent as other recreational destinations, as affluent, if you will, I think we were predisposed to have higher levels of overdoses. I think our service industry people dramatically suffered in this county during the lockdowns and the quarantining and the lack of, employment opportunities in our county, in my county, not our county, in my county for these people. And I also think we got better as time went on. My office basically completely revamped. It became my office in 19, basically the summer of 19. So all this stuff was the old county model. My new model here, I think we're doing a better job of evaluating for overdoses. I think we're catching more. I think we're letting less fall through the cracks. So there's some selection bias here at play as well. And this is dramatic and really shocking when you look at the number of overdoses compared to motor vehicles. Mind blowing that this occurred. We made the flip in 2017, but we haven't looked back since. So you need to report these deaths to me if you're a provider. We generally do really, really well with you giving us the information we need, but for one caveat. When there's a prolonged survival window at the hospital, this person overdoses and then they die a week or two later, even after organ procurement, it's still my case. It does not matter if they survive for a long time, they have lots of comorbidities. The length of time between them dying and them overdosing is irrelevant if you still believe in your professional medical opinion that the overdose is what, and I'm just going to quote, starts the ball rolling. If it starts the ball rolling, then it's an overdose. If you think if this is a healthy 20-year-old person, that's easy. If it's the elderly person that happens to do drugs too and has lots of comorbidities, that's more of a judgment call. But if you think the overdose was at all related, you should bring it up to us. We need to know about it. The overdoses we miss are almost always delayed. If someone dies at the scene, we usually find it. Really, if you feel like the manner of death is something other than natural, like someone murdered them, or they intentionally overdose, or there was some other confounding factor that makes you not want to put a natural manner, that ought to be called in to my office. So once you call, my investigator will ask for additional information and we'll make a decision that day. Then we pay for transport. A majority of these overdose cases will absolutely be autopsy. If they have a prolonged survival window in the hospital with lots of good clinical data to support that it's an overdose, we may or may not autopsy them. Then a minimum, they'll get an external examination. If we have hospital blood that's reasonably early on in their admission, hopefully drawn from the ER very early on, we will also repeat toxicology, sending it to National Medical Services. We'll have a pretty exhaustive panel done on these cases. And at that point, as a provider, this is out of your hands. We'll handle it. We'll certify the death. All right, a real quick break for some entertainment, as I know people expect medical examiners to show interesting cases and photos and stuff. So this is not a Florida case, so this is not purview to the Dale Earnhardt Family Protection Act. This is a South Carolina case, and that state is happy for me to show you the pictures as long as I don't give you reproducible access to them. This case was also presented in the American Journal of Forensic Science and Medicine, so it's in the medical literature as well. So, 35-year-old female is doing drugs with her boyfriend. She becomes sick, dehydrated, doesn't look good. Actually, her well-meaning boyfriend, wanting to provide resuscitation but not actually call 911, goes to the mother's goat farm where they're actively using drugs and finds an expired saline, bag of normal saline, and what appears to be a used IV set that we used several days prior to administer an IV to one of this person's prized goats. These are valuable goats, not just field goats. So here's the IV. That's the site. It's indurated. This is not a good picture. I apologize. And the next picture is going to be what happened. So essentially, this IV set was sitting in this trash can, having been used on a farm animal, which, by the way, are covered in manure and whatnot, kind of growing bacteria. And this guy did get a vessel and basically mainlined bacteria, it turned out to be Staph aureus, directly into her bloodstream and a large bolus of it. And that gives you this appearance, which, if you're not a pathologist, you're looking at a coronal section, a radiologist would get this too. This is a coronal section of your brain. So if you can see my head on the Zoom presentation, it's as if you cut like this. So a coronal section, not sagittal, not axial, coronal, straight down. So what we have here is the right side of the brain and the left side of the brain. We have the gray matter that I'm pointing out. We have white matter. The corpus callosum's been previously cut. I did that. Caudate nucleus, thalamus, putamen, globus pallidus, hippocampus, parietal, temporal lobe in that region there. So what do we have? These innumerable dark spots, hemorrhagic appearing necrotic brain tissue, but almost shotgun blasted across the entire parenchyma. This is not the normal appearance of a brain that has a septic lesion or an abscess cavity. Those are larger single lesions. Cancer would not do this either. Another great example, like the occipital lobe further back, you can see these things get pretty gnarly. And what do they look like under the microscope? Every single one of these is a small nidus of bacteria. This is not a gram stain. This is a hematoxin stain. So this is the Staph aureus right here. And then surrounded by hemorrhage and inflammation and necrosis. A very dramatic picture. Once again, more of the same. You just don't see this appearance. This is a shocking amount of infection. Not surprisingly, other organs were affected too. This is a fibrinous purulent pericarditis. This is the pericardial sac. You're looking at the epicardial surface of the heart anteriorly. The LAD is going to run down here. This is just purulent debris and pus. This infection invades deeply into the myocardial tissue. You're looking at a section here of heart with just geographic areas, this one centered around a vessel, of bacteria and acute inflammation dissecting through the heart muscle. This is as impressive of an acute myocarditis, bacterial myocarditis, as you'll ever see. Very dramatic. All right, so a quick break. We're halfway done. Death certificate. How does this all relay into what we do? Well, if you're certifying, if you're doing this, this is the way as a clinician or a provider, you can help me. You can help me and make my practice better and make the service I give to this community, which is actually the same community you serve if you're working with substance abuse and addiction, is first report the deaths when we need them reported. That way we investigate carefully, and then certify deaths correctly in the cases that don't meet our jurisdiction. Because my office spends an outrageous amount of time recertifying deaths and evaluating things that are certified in a weird manner or a manner that doesn't make sense. At a national level, if you're not certifying these deaths correctly, you're not providing the statistical data that our country needs to appropriately account for all the overdoses that occur in this country. This is what you put on it. It's a scary document, but really, the physician provider does not have that much to add to it. They're important. Litigation, wills and estates, insurance, statistical analysis, but most importantly, closure for the family. Here we have the difference between a pronouncing and a certifying doctor. The pronouncing person is just the person that actually certifies the death. I'm sorry, pronounces the death. They died at this time. The certifying physician is the person that puts what caused the person to die, the cause of death, and then the manner. Now, I've already told you, if the manner's not natural, you need to back up and make sure you're doing the right thing. Chances are it's our case and we'll handle it. This is important verbiage. To the best of my knowledge is the verbiage. This does not say to an absolute degree of certainty, confirmed by testing, none of that. This is your best possible cause based on the information you have available to you at the time you're certified. That's the standard. And it's a pretty light standard legally. All right, there it is. So the cause of death is going to be what initiates the sequence of events that ultimately culminates in death. In other words, what starts the ball rolling. Causes of death could be any number of things. Any of these would be appropriate. Coronary artery disease, COPD, malignancy of whatever. Now, the CDC has very strict, quote, let's call them recommendations, because they don't have any power over you necessarily, on how they want you to certify. So they want you to be very, very granular about what type of malignancy. You know, this is a ductal carcinoma of the left breast. This is an alveolar soft part sarcoma of the right thigh. Status post, I mean, they want you to get really granular. That's not always done. It's not practical. I know why they want it. It's not an absolute requirement. I'll be blunt. I try to keep things general as well when I'm certifying deaths, because quite frankly, the more granular you get, the more data you put on there, the more chance of you being wrong or there being something off. So I try to paint in broad strokes, but still be fairly accurate. So these are also good causes of death. Now the aspiration, the aspiration pneumonia example could very well be an accident if you believe the acute intoxication is what caused them to aspirate. Gunshot wound to the head should not be a natural, obviously. Here's something that we love as medical examiners, and a lot of you guys may not know that it exists. Now, these probably aren't your cases necessarily, or they shouldn't be. They'll be mine. But if you have like someone that has breast cancer, that's not doing well, but they die at home, and there's no autopsy, we've declined jurisdiction, and you're called on to certify, it is absolutely reasonable and acceptable to put complications of metastatic breast cancer, complications of severe, poorly controlled diabetes, whatever that risk factor, that mechanism, that disease process is, you can put complications of that, and that will be accepted by the Department of Health. It's okay. Once again, this is in your best judgment. You're not exactly sure what killed this person, but you are very certain it is related to their very out of control blood sugars, whatever they've got going on. So the manner, of course, the ones you're going to be working with are natural. Other, of course, are what's listed below. Undetermined basically means despite an autopsy, full court press to figure out what happened, we do not actually determine the manner with any real certainty. An example of that would be the skeleton that's found out in the woods. No tissues left. There's no fractures. There's no injuries. There's nothing at the scene that might show us that this is an overdose. So I'm quite literally left with bones and a shirt or a hat. And what do you do with that? Well, I had nothing left to autopsy. I sent it to anthropology. They just say, bones look good, no trauma, no natural disease in the bones. Then it's undetermined. I can't do any more with that case. I can't run toxicology. I can do DNA for identification if I need to, but that's not going to help me determine a cause in a matter. Not as glamorous or as definitive as the crime scene shows would have you to believe, unfortunately. All right. This is what physicians, providers do, not surprising. And now we're going to get into the DC. So we have electronic now, so you don't have to worry necessarily about the paper forms unless you're still doing paper. You basically need to pronounce, if you're pronouncing, then you need to put a reasonable cause of death. So the critical things that I want to talk about here are, the directions are right here. It's a chain of events. A is due to B is due to C. So this is okay above this. If you flip these, you know the coronary artery disease is not due to the respiratory distress. The inverse is true, but that relationship cannot be flipped. That's one of the big problems we see with death certificates. The other thing we see is just respiratory failure or cardiopulmonary arrest. The problem with putting that is, and this is what the CDC will tell you, it's one of their described big major errors with death certificate and death certification, is if you put cardiopulmonary arrest on the death certificate, that's all the CDC is going to get. They don't get the records. So what have you given them? You've basically said this person's lungs and their heart have stopped working. That is true in every single dead person. Another way of saying that is if that was an acceptable and appropriate cause of death, we could quite literally write that on every single person's death certificate the day they were born and just fill in the time of death later. Because I promise you, once they're dead, that statement will be correct. But it gives us no data. It gives us no insight. It gives us no statistical knowledge of how this person died. You can put that and then back it up with something like ASCVD or hypertensive cardiovascular disease or metastatic breast cancer or sepsis of some description, but you can't leave that be a standalone cause of death. That's the biggest offense. This is one that I would do. You shouldn't be having to fill out. If you find yourself filling out the how injury occurred section, you need to back up and say, aha, maybe the medical examiner should be called here if you really truly believe that this is why they died. Once again, if they have the aspiration pneumonia, but you think that this hip fracture and the resulting hospitalization, surgical fixation were contributory, that's still our case. We do these cases all the time, probably 2 or 3 a day. And then sign it, and then you're good to go. So this is a year of data we collected in South Carolina, basically looking at how clinicians did certifying death. And these are as described by the CDC. I did not make these up. The minor things are really not a big deal. I'm not worried about it. The major ones are the problems, particularly when you have the non-specific cause of death standing alone, because once again, cardiopulmonary arrest on the death certificate doesn't help anyone. We don't know what you're talking about. The inaccurate sequence, oftentimes a medical examiner or another clinician can piece together what you were trying to say, but it's still tough. It would be nice if it was done correctly. Oh, shoot, I'm sorry, I hit my mouse. And then omitting the significant conditions, if those are important, obviously they should be included. So wow, this is what the study looked like. It was only 125 that were certified by clinicians. It's a smaller hospital. But as you can see, a lot of these cases contained errors. Very few contained almost no errors. Some contained minor errors, but the vast majority contained some. This is the big offender for coding. That 20% almost, or that was an issue. That's going to affect coding. Omitting that critical condition is going to affect coding to a degree, but to a less likely probably. And then of course the inaccurate. We can work through some of these, but it depends on how it's done. Ideally, we're going to eliminate these. So the future direction for this study is for us to actually make the little ID card flip things, like a card behind your card, like you have for ACLS or fires or whatever, on how to certify a death certificate. And we're hoping when that resident or whoever is certifying that death at late night has no one else to go to, they'll look at that and not put cardiopulmonary arrest. So, gonna finish early, time for questions. In summary, as you know, overdose is a major problem, critical public health crisis. COVID, I believe, significantly increased overdose. Nothing else really significantly changed. Perhaps my office getting better at screening for overdoses, but COVID is the 800-pound gorilla here. This is what drove the increase in overdoses, at least in our jurisdiction. I'm confident of it. That population, the population you serve, did not do well with COVID. I know you know that from personal experience. I think my data corroborates that. If you're a provider / clinician, you need to certify deaths correctly. If you're thinking about it being a non-natural, call us. And then if the case is an overdose, regardless of time intervals, call us. We need to know. If you don't tell us about it and we find out after the fact, it may be completely ignored. Or I can give an example. We review cremation certificates. So oftentimes we'll see the words probable overdose appear on a cremation certificate. We won't get that cremation request from the funeral home for a couple weeks. So by that time, the body's been cremated. I'm not cremating. The body's been sitting for weeks, maybe refrigerated, hopefully refrigerated, but still doing a good autopsy at that point in time and getting a good toxicologic specimen at that time is much more difficult. So with that, I'll end and take any questions you have. Thank you so much for your attention. You should have the slides of the data. I do not provide the autopsy slides just because I don't want those pictures running around in the internet. So I'll take any questions at this time and stop sharing.
Thank you so much, Dr. Fulcher. At this time, if you have any questions, you may raise your hand using the button at the bottom of your screen. We will call on you and allow you to unmute yourself. We will also alternate between the chats. So you may either place your question on the chat or raise your hand. On the chat, we have a comment, wow, interesting. And I believe that's when you were showing the pictures of the 35-year-old case. And
yeah, I could have showed a lot more cases, but I don't think that was in the overall nature of the conference. So I decided I wouldn't do too many. Maybe next time, come back.
Thank you for sharing, though. That was very interesting. Do we have any questions from anyone? I do not see any questions. Okay. I have read that fentanyl can cause wooden chest syndrome. Do you see evidence of this?
We do not, and I know these things are possible. The thing to realize about us is I work in a world of strict anatomy and histology and toxicology. So if there's any sort of if there's a physiologic component, I don't see it. So physiology basically goes away. So there's things I'm really not good at. Like, for instance, seizures is a great example. A lot of seizure foci are microscopic. We have a very difficult time finding those at autopsy. Stuff like that. So if it's a physiologic process or something like it, we're not going to be the ideal people to evaluate those cases. Any sort of psychiatric illness, of course, we have a very difficult time evaluating. But that is a good question. Let me make sure wooden chest syndrome is exactly what I remember it as. It's been a long time since I thought of that.
Any other questions?
Chest wall rigidity. Yeah, so that's going to be a physiologic process. You keep in mind, and this is kind of self-explanatory, the entire body is rigid when we get it with rigor mortis, and then it eventually goes away as rigor passes, as the actin and myosin binding in the muscles break down. I just saw a new chat on other things coming up.
Have you
Great
seen?
question. That's a great question. I will tell you, we get a phone call, an email every other day from our toxicology lab, National Medical Services, on a new fentanyl analog. So I will tell you, parafluorofentanyl is one you'll see. I will tell you, we have seen 0 cases that I can think of carfentanil, the elephant tranquilizer. That has not appeared recently. It's been years. The general trend is increasing concentrations of fentanyl, nearly all of it clandestinely made in our overdose population. We know that because of contamination with other drugs that are not prescribed to that decedent, and also the presence of 4-AMPP, which of course is a byproduct of fentanyl metabolism, but also largely used in the clandestine manufacturing of fentanyl. At the end of the day, I think the most important thing is that the toxicology labs are struggling to keep up with the actual varieties of drugs, and it's an ongoing process. And if you ask me this a year from now, there'll be a completely different batch of toxins that are present. I will say, this is with COVID, but I think in Florida particularly, concentrations of fentanyl in decedents has just kept going up. We try not to say there's a hard and fast fatal level. That actually came into play in George Floyd and that situation with his fentanyl level. And what we're learning is that habituated users can use a lot more fentanyl and have much higher concentrations of fentanyl than our literature initially suggested in naive users. So we used to say fatal started at 3 nanograms per milliliter. We know there are plenty of people that are functional at that level now. But with that said, we see people in the hundreds, 150 massive doses of fentanyl. And we believe it's due to just the supply chain being basically filled with extremely powerful drugs. That probably wasn't cut like whoever produced this thought it was going to be cut a lot more than it was. I think that's the only explanation. Great question though. Other than that, other trends, I can't think of anything really exciting or interesting. It's all fentanyl. People that come to us thinking they're doing meth, thinking they're doing heroin, thinking they're doing whatever. Fentanyl nearly always occurs in some concentration in that drug product. It's just in all of them now. Great questions. You're welcome, Whitney.
Anyone else?
Next time I'll bring more cases. Sorry, we finished early.
Thank you, Dr. Fulcher. All right, then, thank you, Dr. Fulcher, for sharing your expertise today. Attendees, please use the link in the chat to complete the evaluation survey for this session. We thank the Florida State University for managing the summit evaluations. If you requested CEUs, please do not forget to complete the CEU survey in order to receive the CEUs you're requesting. Thank you, everyone, for participating and attending this session. We hope you will be attending tomorrow's sessions. Please go to your summit program PDF or visit thepathforhope.com/summit 2021 and click on the link for tomorrow morning's brief welcome session. Again, thank you so much and have a wonderful afternoon. I will now end the meeting. Thank you, Dr. Fulcher.